Without any further delay, let me introduce today's speakers, Dr. Anne-Marie Valente and Dr. Tal Jiva. Dr. Valente has no disclosures to make in relationship to this activity. Dr. Jiva is a consultant to Medtronic. After review of content by the CME committee, it was determined there is no actual or potential conflicts of interest in relation to this webcast. Dr. Anne-Marie Valente is the outpatient director of the Boston Adult Congenital Heart and Pulmonary Hypertension Program and co-director of the Pregnancy and Cardiovascular Disease Program at Brigham and Women's Hospital. Dr. Valente has been a faculty member in the Department of Cardiology at Boston Children's Hospital and Department of Medicine Division of Cardiology at the Brigham and Women's Hospital since 2006. She's an assistant professor of medicine and pediatrics at Harvard Medical School and is a founding member of the Alliance for Adult Research in Congenital Cardiology Group. Dr. Jiva is a professor of pediatrics at Harvard Medical School and chief of the non-invasive division in the Department of Cardiology at the Boston Children's Hospital. He assumed his current position at Boston Children's Hospital in 1994. Dr. Jiva established the cardiac MRI program and assumed his current position as chief of the non-invasive imaging division in 2005. He was president of the Pediatric Council of the American Society of Echocardiography and a member of the Society's board of directors. Dr. Valente and Dr. Jiva, I will now turn the presentation over to you.
Thank you very much, Rona. Good afternoon, everyone, and thank you for joining us. In this session, we will be discussing the following guidelines document, which was developed in collaboration with the Society for Cardiac Magnetic Resonance and the Society for Pediatric Radiology, and this was published in the Journal of the American Society of Echocardiography several months ago. Our aim is to describe the roles of each imaging modality in the care of patients with Tetralogy of Fallot, recognizing that the choice of these modalities is often dictated by patient factors as well as modality-specific factors and clinical circumstances. The following is our outline for this session. Tal will discuss some background information regarding patients with Tetralogy of Fallot. Then, recognizing the anatomic and hemodynamic sequelae that occur, we will focus our attention on the goals of imaging. Next, we will discuss the strengths and limitations of each imaging modality, and finally summarize our multimodality approach. Tal?
Good evening, everybody. Thank you, Anne-Marie. Tetralogy of Fallot is the most common form of cyanotic congenital heart disease with an incidence of nearly 33 affected newborns per 100,000 live births. And in the United States, there are approximately 1,300 new patients with repaired Tetralogy of Fallot that are born every year. The two pictures at the top of the slide demonstrate the anatomy of Tetralogy of Fallot. You can see on the left-hand side a specimen of a patient with unrepaired Tetralogy of Fallot. This is a pathology specimen in which the right ventricular free wall has been removed, and you're looking at the opened right ventricle. And on the left side, there is a diagram showing the structures. And what you can see here is that Tetralogy of Fallot is a malformation in which the conal septum, this is this structure that separates between the aortic valve and the pulmonary valve, is deviated from its normal position about here, anteriorly and superiorly, such that it exposes a large ventricular septal defect here, if you can follow my arrow. It then narrows the right ventricular outflow tract, resulting in infundibular or subvalvular pulmonary stenosis, as well as pulmonary valve stenosis and typically hypoplasia of the main and branch pulmonary arteries. As a consequence of the obstruction to blood flow out of the right ventricular outflow tract, the right ventricle is hypertrophied, and the aorta overrides the ventricular septum, so you can see the aortic valve very clearly here, sitting above the ventricular septal defect. So this is how these patients begin their journey. The physiologic consequences of tetralogy of Fallot is that blue blood or deoxygenated blood has hard time getting out of the right ventricle due to obstruction in the outflow tract and flows into the aorta, mixing with the red blood that comes back from the lungs into the left ventricle, and the result is cyanosis. And you can see this picture of a baby. You can see the perioral cyanosis right here. And if this is allowed to go on for a long period of time, these patients develop clubbing of the nail beds, which you can see on the right-hand side. The history of tetralogy of Fallot and its treatment is fascinating indeed. The anomaly was first described by Niels Stenson in 1671, and Arthur Louis Fallot published his series of papers in 1888. And by the way, Fallot did not name the anomaly after himself. This happened in the early 1900s when his contribution was recognized. This anomaly has been without treatment, and the majority of these patients died at a young age until 1945, when the Blalock-Taussig shunt was developed, and I'll describe this in a little bit more detail in the next slide. And nearly 10 years later, the first open heart repair or complete repair of this anomaly was performed in 1954 by Walton Lillehei at the University of Minnesota. And then nearly 20 years later, primary neonatal repair has started to gain popularity. And a repair of tetralogy of Fallot has become better, more reliable, with decreasing mortality and morbidity. And for now, nearly 15 years, what we have been focusing on our attention is on late complications and prevention of these complications. The pictures here show Helen Taussig, who is one of the founding mothers of the field of pediatric cardiology, and Dr. Taussig was amongst the first to care for these patients. And what she noted is that those babies or young children who had a continuous murmur tended to do better and to live longer as compared with those who did not. So Dr. Taussig figured that these patients must have a patent ductus arteriosus, which used to be thought as the only cause of a continuous murmur. So she went to Boston and asked Dr. Gross to create an artificial PDA in those patients in the hope that these will do better with more oxygenated blood going into the lungs. And Dr. Gross refused to do that. He told, so the story goes, Dr. Taussig, that he closes PDAs. He doesn't create them. So she went back to Johns Hopkins and talked to Dr. Alfred Blalock, who was working in the dog lab at the time, trying to create a dog model of pulmonary hypertension, and together with Vivian Thomas, who was his assistant and had a major role in developing the surgical technique to create these shunts. And they agreed to perform that procedure in a patient. And this was the origin of management of tetralogy of Fallot by placing a shunt between the left subclavian artery and the left pulmonary artery in those with left aortic arch, and of course doing the same thing on the right side in those with right aortic arch. And that was published in the Journal of the American Medical Association in 1945 and changed the face of pediatric cardiology and pediatric cardiac surgery. The first repair is credited to Dr. C. Walton Lilleha in 1955, and this repair includes patch closure of the ventricular septal defect, an enlargement of the right ventricular outflow tract, relief of the right ventricular outflow tract obstruction, which can be done either by resection of obstructive tissue, removal or enlargement of the pulmonary valve, or placement of an RV to PA conduit. However, this repair is not truly repair. It is more a palliation in the sense that the surgery leaves behind important hemodynamic abnormalities, including disruption of the pulmonary valve, creation of pulmonary regurgitation, which leads to chronic volume load on the right ventricle, in some patients also pressure load. And the result of that is seen in this heart specimen of a patient who died at a relatively young age, years after Tetralogy of Fallot repair. You can see here the patch that used to close the ventricular septal defect, the massively dilated and hypertrophied right ventricle. Look at this wall thickness here. This is the patch that used to enlarge the right ventricular outflow tract, and basically what you're looking here is at a cardiomyopathy involving predominantly the right side of the heart, but also affecting the left side of the heart. So the result is right ventricular dilatation, dysfunction, hypertrophy, development of scar tissue, and diffuse fibrosis, and in many of these patients, left ventricular dysfunction as well. And what we have observed now by several studies, and I'm showing you here data from 2 large studies, is that there is an accelerated rate of mortality and morbidity beginning during the 3rd decade of life in this patient population. You can see here in the study of Fallot and colleagues that the mortality rate is relatively flat or fairly low, 0.27% per year until the 25th year after surgery, and then the mortality rate triples afterwards. In the study of Paul Carey and his colleagues, this is a multi-center study looking at arrhythmias late after Tetralogy of Fallot repair. You can see here the accelerated rates of major arrhythmias in these patients, again beginning in the 3rd and 4th decades of life.
So in considering the long-term postoperative anatomic and hemodynamic issues in these patients, let's start with a question. This is question number 1. The most common hemodynamic sequelae of repaired Tetralogy of Fallot is, number 1, left ventricular dysfunction, number 2, aortic stenosis, number 3, pulmonary regurgitation, number 4, right ventricular hypertrophy, or number 5, systemic to pulmonary venous collaterals. Please key in your answers. Great. So what we're seeing is that the majority of the group that responded chose pulmonary regurgitation, and that is indeed correct. When we look at the other choices, if you look at the individual choices, situations such as aortic stenosis or systemic to pulmonary venous collaterals are exceedingly rare in this population. Now, number 1, left ventricular dysfunction may occur even in up to as many as 20% of adults, which can be really important regarding long-term outcomes. However, pulmonary regurgitation is much more common in these patients. The other answer, right ventricular hypertrophy, is often associated with elevated right-sided pressures, and that also is worrisome, but not as common as pulmonary regurgitation. So we'll move on. This is Table 1 in our document, and it lists the structural and functional abnormalities that we see in these patients. Now you can see that there are many structural abnormalities that could be from different mechanisms, such as those inherent to the original Tetralogy of Fallot repair. They're listed here. There are also residual and recurrent lesions that occur, acquired lesions, and associated anomalies. From a functional standpoint, there are several mechanisms that create both right ventricular volume or pressure overload, and we've listed them here. Additionally, there are varying degrees of right and left ventricular dysfunction, as well as certain electrophysiologic factors that come into play, such as ventricular conduction delays and dysynchrony, as well as both atrial and ventricular arrhythmias. So the overarching goals of imaging are to identify the various anatomic and functional abnormalities that occur in these patients and assess their severity. And doing that, we want to provide information that's going to help inform clinical decision-making. This slide is a list of essential data elements that should be assessed with imaging. If you look at these, determining right ventricular size and function is important, as well as assessing for any tricuspid regurgitation, and when present, looking for the mechanism of tricuspid regurgitation. We also need to estimate the right ventricular pressure and evaluate the right ventricular regional wall motion, as well as the right ventricular outflow tract, its anatomy, and its function. We look at the status of the main and branch pulmonary arteries, and we also determine the severity of pulmonary regurgitation. Quantifying the left ventricular size and function is important. As previously mentioned, LV dysfunction is an independent risk factor for poor outcomes, namely ventricular tachycardia and death in patients with repaired Tetralogy of Fallot. We assess the aortic root size and the diameter of the ascending aorta, recognizing that certain subsets of patients with tetralogy are particular high risk for having aortic dilation, such as those that were born with pulmonary atresia. We assess for aortic regurgitation, as well as sidedness and anatomy of the aortic arch. Determining the origins and the proximal courses of the coronary arteries is particularly important, especially before considering any further right ventricular outflow tract interventions. We look for residual shunts and any evidence of collateral vessels. So now that we've identified the goals of imaging, let's consider how the individual modalities are used to evaluate patients with a repaired Tetralogy of Fallot. We will discuss the following 5 modalities: echocardiography, cardiac magnetic resonance, cardiac computed tomography, nuclear scintigraphy, and X-ray angiography. And in doing this, we recognize that no single modality is capable of providing all the necessary data, so it's important to understand the strengths and limitations of each modality.
As I am quite sure the majority of people joining us in this webinar are aware, echocardiography is the bread and butter of non-invasive imaging in congenital heart disease, and Tetralogy of Fallot is no exception. We use echo every day, and essentially every patient with repaired Tetralogy of Fallot is evaluated by echo. The diagnosis is established by echo, increasingly prenatally. It is used as the primary diagnostic modality for preoperative planning, and echo has a major role after surgery and throughout follow-up in these patients. However, the type of information and the strength of echo changes as these patients grow. Echo has important strength. It is inexpensive, widely available, and portable. There's extensive experience with echocardiography for many decades, and a large body of information. Very importantly, especially in children, is that echo does not expose patients to ionizing radiation with its attendant risk of cancer. The main limitations of echo is that it becomes increasingly more difficult to get good images, which means good data, in patients with repaired tetralogy of Fallot as they grow and becomes adults. There's also challenges in quantification of certain elements of the physiology in these patients due to a number of reasons, including the difficulty in imaging the entire right ventricle because of its retrosternal position, as well as scar tissue and intervening lung and air in patients after repaired tetralogy of Fallot. Difficult to measure blood flow, but some of these are mitigated by using a multimodality approach, as we will discuss in this webinar. We use all available echocardiographic tools at our disposal when we evaluate patients with repaired tetralogy of Fallot. We use 2D for evaluation of anatomy and function, and we look at all aspects of the heart and great vessels by 2D. We evaluate the structures for multiple acoustic windows, and of course, the utility of these windows change as patients age. So in young patients after repaired tetralogy of Fallot, the subxiphoid or subcostal window is particularly robust and helpful, but as patients grow, apical, parasternal, and suprasternal windows assume greater roles. We use Doppler primarily to evaluate RV and PA pressure. We also use tissue Doppler imaging to assess myocardial function in these patients. More recently, the advent of myocardial deformation imaging and with measurements of strain and strain rate is increasingly being utilized and may have a particularly strong role in the in evaluation of RV function in this patient population. The role of 3D echo is evolving. It is particularly helpful for assessing valve morphology. So tricuspid regurgitation is an important problem in patients with repaired tetralogy of Fallot, and 3D echo can be instrumental in evaluating the mechanism of the tricuspid regurgitation. So it allows detailed evaluation of valve morphology, motion, location of the regurgitation, and this can aid in planning tricuspid valve repair. Another potential role of 3D echo is for volume measurements of the right ventricle, so assessments of right ventricular end diastolic and systolic volumes, as well as RV ejection fraction. Data that is now in press suggests that the utility, the ability to get full RV volumes in patients with congenital heart disease is very good during the first decade of life and becomes increasingly more difficult beginning in the second decade of life and in older patients. Transesophageal echo and intracardiac echo are modalities that can be helpful in selected patients, especially for valve anatomy, image guidance during interventional procedure, and to answer selected questions. The guidelines document provides a very detailed imaging protocol for echocardiography. This slide only provides a summary. Again, you can see here that we use a combination of 2D, when appropriate 3D imaging, color and spectral Doppler, tissue Doppler imaging, and strain imaging whenever applicable. We use multiple acoustic windows. The subxiphoid window is especially helpful in young patients and gives excellent images of the RV. the subxiphoid right anterior oblique view. That is a view that shows both the inflow and outflow of the right ventricle is particularly helpful. The apical 4-chamber view, as well as the 3-chamber and the LV 2-chamber, are all views that demonstrate both RV and LV very well and allows for assessment of size and function. The parasternal long and short axis views are standard echocardiographic views, and the suprasternal notch is especially important for assessment of the branch pulmonary arteries as well as the aorta. The high right parasternal view is useful for evaluation of the ascending aorta that may be difficult to see in standard parasternal long axis view, as well as the SVC and the right pulmonary artery. One of the important challenges in repair tetralogy of Fallot is the presence of pulmonary regurgitation. Echocardiography, especially Doppler echocardiography, is a useful tool for grading pulmonary regurgitation, and studies that have compared Doppler indices to flow velocity mapping by MRI, which is the gold standard, have shown that the two most useful methods that can be used in combination is the profile of the regurgitation, the pulmonary regurgitation jet. This is the spectral Doppler, is one parameter to evaluate, and the other one, shown here in the lower panel, is the degree of flow reversal in the branch pulmonary arteries. In mild pulmonary regurgitation, the PR spectral Doppler demonstrate gradient between the MPA and the RV throughout diastole. So you can see here spectral Doppler signal throughout diastole with a gradient all the way until next systole. In severe pulmonary regurgitation, there is rapid equilibration of the diastolic pressure between the main pulmonary artery and the right ventricle, and this results in a relatively short duration of the regurgitation jet with rapid equilibration of the pressure and a long period of low flow or very little antegrade flow, which is often accentuated in late diastole during atrial contraction. Moderate pulmonary regurgitation is somewhere in between mild and severe, and typically there would be this long tail of tapered gradient, which is very low towards end diastole. In the lower panel, you can see the different flow profiles and patterns of flow reversal in the branch pulmonary arteries. Here, pulse Doppler is interrogated in the left pulmonary artery, and what you see here is a very short, early diastolic flow reversal with no flow during most of diastole. In severe pulmonary regurgitation, you see hollow diastolic flow reversal in the left pulmonary artery, and moderate pulmonary regurgitation is a pattern that is between mild and severe. Another challenging repair tetralogy of Fallot is tricuspid regurgitation. Trivial or mild tricuspid regurgitation affects almost every patient with repair tetralogy of Fallot, but moderate and severe tricuspid regurgitation produces a hemodynamic burden that is important to address typically during reoperation in these patients. A common mechanism for tricuspid regurgitation in patients with repaired tetralogy of Fallot is damage to the anteroseptal commissure of the tricuspid valve due to the VSD patch that was placed at the time of repair. That VSD patch then damages the anteroseptal commissure, which may get widened over time, and this is a source of tricuspid regurgitation. This apical fold chamber image with color flow mapping demonstrates a jet that originates medially close to the septum, and typically this is the location of regurgitation through the anteroseptal commissure. When you evaluate patients with repaired tetralogy and tricuspid regurgitation, it is important to delineate the mechanism of the regurgitation, and options for different mechanisms include damage to the anteroseptal commissure, as I have just mentioned. In addition to that, annular dilatation, usually secondary to right ventricular dilatation, is another mechanism. In addition to that, right ventricular dilatation results in displacement of the papillary muscles, especially the anterior papillary muscle of the tricuspid valve, and as a result, the anterior leaflet is, especially the tip of the anterior leaflet, is pulled toward the midline and away from the septal leaflet, resulting in non-coaptation. This jet is typically central. And then, of course, another mechanism is congenital abnormality of the tricuspid valve. And all of these mechanisms need to be evaluated, as this information is crucial for planning surgical repair of the tricuspid regurgitation. Assessment of the severity of TR is based primarily on the width of the vena contracta, which can be measured from the apical fold chamber view, as well as from an orthogonal view, typically a parasternal long axis view, tipping the transducer towards the right hip. So it's important to evaluate the vena contracta from at least two different views in order not to rely on a single plane. Another measure that is gaining interest in adults with functional tricuspid regurgitation and in patients with pulmonary hypertension is the coaptation height and area, is shown in this figure. Assessment of right ventricular function is a particular challenge in these patients. The right ventricle is difficult to image in its entirety in one image or from one plane or from one transducer position, because the right ventricle is located immediately behind the sternum. In patients with tetralogy, it is often dilated and its shape is abnormal and does not conform to any typical geometric assumptions. Methods to assess RV size include tracing the right ventricular end diastolic and end systolic areas from the apical fold chamber view, and this measurement has modest correlation with MRI measured RV volume. Another method is to measure the diameter of the right ventricle in the apical fold chamber view at the base and at the mid-right ventricular levels. And all of these are described in detail in the American Society of Echo position paper on assessment of the right ventricle. Assessment of right ventricular function can be done using several echocardiographic techniques. Here, this slide shows TAPSE. This is tricuspid annular plane systolic exertion, and a typical method to do that is by placing an M-mode cursor through the tricuspid valve lateral annular position here, and to measure the distance between end diastolic position and end systolic position, and this gives you an idea or measures the displacement of the tricuspid valve during systole towards the transducer. In this particular case, this distance is nearly 16 millimeters, which is normal in adult patients. In this patient with severe RV dysfunction, the TAPSE measured 4.4 millimeter. And you can see this markedly diminished TAPSE in this patient. What you must remember is that TAPSE is not the same in young patients with small body size as it is in adults, and you cannot use adult norms in younger children because the heart grows as these patients grow, and the amount of excursion is related to body size, and this must be taken into account. And normal values in children for TAPSE have been published, and you can find the reference in the guidelines paper. Another method to measure RV function is by using tissue Doppler and of the lateral tricuspid annulus, and you can see here example of normal function in a patient with S prime velocity of 14 centimeter per second, and here in the left panel, in the right panel, you can see here patient with markedly depressed RV function with an S prime velocity of about 7 centimeters per second. A good number to remember is 10 centimeters per second, which below that studies have shown is associated with depressed RV function as measured by cardiac MRI. And with this information in mind, let's move on to question number 2. Please look at the video clip on the left side and at the Doppler tracing on the right side going through the right ventricular outflow tract and main pulmonary artery. And the question is, which of the following statements is true in this particular patients with repaired tetralogy of Fallot? Notice that the peak gradient across the RVOT is 25 millimeters of mercury with a mean gradient of 14. And the question is, which of the following statements is true in this patient? 1, the right ventricular size is most likely to be normal. 2, a peak gradient of 25 millimeters of mercury across the right ventricular outflow tract is an underestimation of the true degree of stenosis. Number 3, the patient is most likely very symptomatic. And 4, the spectral Doppler signal is consistent with at least moderate pulmonary regurgitation. Please vote. Very good. The majority, 67%, indeed got the correct answer, which is the spectral Doppler signal is consistent with at least moderate pulmonary regurgitation. Let me just go back and show this to you. And you can see right here as the movie clip plays, what you see in this color compare video clip, you can see here to and through flow through the right ventricular outflow tract. The Doppler alignment across this RVOT is actually very good, and there's no reason to suspect that the estimation of the gradient is inaccurate or underestimated. And when you look at the spectral Doppler of the regurgitation jet, it certainly more than mild. you would not assume that RV size is most likely to be normal given the degree of pulmonary regurgitation. We discussed that the peak gradient of 25 millimeters of mercury is quite reliable in this case, and this patient is not likely to be very symptomatic, certainly not during the first 10 or 20 years of life. And I will turn the podium to Anne-Marie, who will discuss cardiac MRI with you.
Terrific. Thank you. So moving on to the second modality, cardiac MRI is the reference standard for quantification of right ventricular size, function, and pulmonary regurgitation. It allows for comprehensive assessment of the cardiovascular anatomy, function, flow, as well as myocardial viability. The data that we generate from CMR are being used for guiding clinical decisions. And once patients reach adolescence and into adulthood, CMR is recommended as a routine test for follow-up. Now, a common question that comes up is how often to do this imaging, and we're going to discuss that a little later when we talk about the multimodality recommendations. The strengths of cardiac magnetic resonance are that it provides a comprehensive assessment of morphology and physiology, and it is independent of acoustic windows. It also provides accurate and reproducible measurements, and additionally, the absence of ionizing radiation makes it very appealing for longitudinal follow-up. Limitations include a higher cost, lack of portability, limited availability, and additionally, there's artifacts from stainless steel coils. Pacemakers and defibrillators are relative contraindications to cardiac magnetic resonance. The document provides a detailed protocol for cardiac magnetic resonance imaging, and this slide presents a summary of that data. We also included a table here, which is Table 5 in the document, which gives gender-specific reference values for both ventricular size, function, and atrial volumes. Let's look at some specific views that we do in patients with repaired tetralogy of Fallot. There are several ways to evaluate the right ventricular outflow tract. Shown here is an oblique sagittal plane through the long axis of the RVOT and main pulmonary artery. This white arrow is indicating a right ventricular outflow tract aneurysm. Now, several MRI sequences can be used to evaluate the right ventricular outflow tract. This is a still frame example of a cine SSFP, which is helpful because with this, you can see wall motion abnormalities such as akinesia or dyskinesia of these patched areas. Additionally, SSFP allows us to identify obstruction by a combination of observing the anatomic narrowing that may be present, as well as a systolic signal flow void in that location. We can also use SSP imaging to identify thrombus. This image in panel A is a different view that includes both the RV inflow and the RV outflow, and you can see this dark area at the right ventricular outflow tract that may be consistent with thrombus. To confirm the presence of a thrombus, we administer gadolinium contrast and then use a long inversion time, and you can see that area, now very dark, is consistent with thrombus within the right ventricular outflow tract. This image is illustrating an additional way to look at the right ventricular outflow tract. This is a volume-rendered, gadolinium-enhanced MRA, and it provides a 3D representation of a very large right ventricular outflow tract aneurysm. This demonstrates how cardiac MRI is helpful in understanding the right ventricular outflow tract geometry. This is particularly important prior to considering any percutaneous pulmonary valve interventions. Here's an example of a volume-rendered MRA reconstruction. The arrow is indicating proximal right branch pulmonary artery stenosis. Now, this may have been at the site of a prior right Blalock Taussig shunt, or it may not have been associated with a prior surgery. But this would be a situation where we would want to measure branch pulmonary artery flow with phased contrast imaging. MRA is also a valuable tool here because it provides depth perception, and you can visualize the complex relationships between the pulmonary arteries and neighboring structures. When we are assessing the branch pulmonary arteries, you may use other techniques such as turbospin echo black blood imaging, which is helpful due to the higher spatial resolution and the fact that it is less susceptible to metallic artifacts such as pulmonary artery stents. Now, referring back to our first question, we recognize pulmonary regurgitation is a very common sequelae of tetralogy repair, and cine phase contrast MRI imaging is the reference standard to quantify this. The image is obtained perpendicular to the long axis plane of the proximal main pulmonary artery, and a phase map is obtained, and then software is created which gives you a graph of the flow rate over time. We can calculate the pulmonary regurgitant fraction by taking the retrograde flow, shown here in blue, and dividing it by the antegrade flow, shown here in red. This will be the pulmonary regurgitant fraction. You can also report the pulmonary regurgitant volume. It's important to be able to confirm that data, and you can do that by looking at the difference in your ventricular stroke volumes, assuming no other significant valve regurgitation, shunts, or significant late diastolic antegrade flow in the main PA. Besides assessing ventricular volumes, function, and mass, we also look specifically at the myocardium with the technique of late gadolinium enhancement. We use gadolinium contrast, and after 10 to 20 minutes, look at the myocardium. Viable areas are black, as shown here. Non-viable myocardium, such as the area of the right ventricular outflow tract, as indicated by the yellow areas, is in white. The non-viable areas may extend beyond the surgical site, as shown in red, here at the superior surface of the right ventricle, and may even involve specific sites such as the inferior septal insertion site, which is very remote from prior surgery. This late gadolinium enhancement has been associated with exercise intolerance, ventricular dysfunctions, and arrhythmias, but the prognostic value for hard clinical outcomes such as death has not yet been established, and this is one area where newer techniques such as quantifying diffuse fibrosis by T1 mapping might be helpful.
Switching gears to cardiac CT, this is a technique that is being used sparingly in patients with repaired tetralogy of Fallot. Here we are acquiring a volume of data during a single breath hole examination, and we use it only when we cannot use MRI. For example, patients with pacemakers or ICDs. Otherwise, echo and MRI are being used as the standard imaging techniques in these patients. Cardiac CT has an excellent spatial resolution. In fact, the new generation of modern scanners can give you a spatial resolution of less than 0.3 millimeter by 0.3 millimeter. It can image structures that are obscured by stainless steel metallic artifacts on MRI. On the other hand, cardiac CT exposes patients to ionizing radiation and to contrast, which has a potential nephrotoxic effect. The temporal resolution of cardiac CT is lower than that of cardiac MRI, although newer scanners have improved as compared with older generation CTs. Nonetheless, it does not come close to the temporal resolution of MRI, and cardiac CT does not provide information on blood flow. This is an example of the kind of images you can get with cardiac CT. This is a patient with stents in the main and branch pulmonary artery. In A, you can see a sagittal view showing the stent in the RVOT and MPA, which is widely patent, and this is a stent in the branch pulmonary arteries. And you can see the same RVOT and branch pulmonary arteries, which have stents in them, to be widely patent. Notice that CT is capable of imaging inside the stent very clearly. You can also see adjacent structures such as the aorta. This is the right coronary artery, superior vena cava, the left and the right main stem bronchus, as well as the lung tissue surrounding the heart. Here's another example of volume-rendered cardiac CT showing the relationship of the coronary arteries to the RVOT and then to the stented conduit right here. And you can see that the conduit goes over the left anterior descending coronary, which is an important consideration when balloon dilating or placing a transcatheter valve in the RVOT with regard to the possibility of compression of the left anterior descending coronary. And just one more CT image to demonstrate the use of CT in a patient with an AICD. You can see it here with the red arrow in the RV. And in this patient, sinus CT was used to quantify RV and LV volumes and ejection fraction in preparation for pulmonary valve replacement.
So moving on to nuclear scintigraphy, it is a modality which uses radioisotope-labeled compounds to capture and quantify blood flow, myocardial perfusion, and ventricular function. Its diagnostic utility is only in highly selected circumstances. And that is, the two main uses of nuclear scintigraphy are to measure differential pulmonary blood flow, and it has been well validated to look at left ventricular perfusion and viability, which is becoming particularly important in our patients with Tetralogy of Fallot as they become older and are more susceptible to coronary disease. However, this technique has several limitations as well. There is exposure to ionizing radiation, and it has not been well established for assessing the right ventricle. It is also not appropriate to measure differential pulmonary blood flow if there are multiple sources of pulmonary blood flow. The final modality we'll be discussing is X-ray angiography. It serves an important role when essential information cannot be accurately obtained by non-invasive methods, and it's an integral component of certain catheter-based procedures as listed here. The strength is it is the gold standard for measurement of intracardiac pressures, coronary arteries, and branched pulmonary arteries, but it too has limitations such as its invasive nature, the exposure to radiation, and the cost. Just a few examples of specific imaging that may be helpful. This is a still frame of rotational angiography, which is particularly useful for visualizing the branched pulmonary arteries. You can see here in this patient, there's narrowing of the origin of the LPA. The RPA has a stent placed proximally, and then there's severe RPA stenosis following that stent. MPA angiography can also be performed using specifically caudal angulation, which outlines the PA bifurcation in detail. And here you can see that there is stenosis of the right pulmonary artery as well. Lastly, selective coronary angiography sometimes needs to be performed, particularly if you're considering a percutaneous pulmonary valve, to ensure that there is no coronary compression when a balloon is blown up in a right ventricular outflow tract conduit.
So to bring it all together, the purpose of this document is to outline a roadmap for multimodality approach in this patient population. None of the imaging modalities that we have discussed this afternoon is perfect. None of the imaging modalities is capable of delineating all aspects of all information that's needed in these patients, and therefore the use of these modalities in concert is essential. At the same time, we cannot use every modality in every patient all the time. We have to be cognizant of resource utilization as well as the limitations and potential harm of especially ionizing radiation. This table summarizes our recommendations for use of echo, MRI, CT, lung perfusion scan, X-ray angiography, and chest radiography in patients with repaired tetralogy of Fallot. And you can see that these recommendations vary by age and by specific circumstance. So in summary, patients with repaired tetralogy of Fallot have residual anatomic and hemodynamic abnormalities. No single test is capable of providing all necessary diagnostic information in all clinically relevant circumstances. Echo is the primary imaging modality in the first decade of life. However, in adolescence, cardiac MRI is the imaging modality of choice for routine surveillance, and other modalities are used in selective cases. Thank you for your attention, and we will perhaps spend several minutes answering questions if this is allowable. So James Adams is asking, with the advances of 3D echo deformation imaging and the fractional area measurements and TAPSE, with good correlation with cardiac MRI, is the frequency for cardiac MRI now as necessary? That's an excellent question. And this is perhaps the goal of these advanced echo techniques, and that is to use MRI more sparingly. And certainly during the first decade of life, so during the first 10 years of life, MRI is certainly not used routinely, and echo is the modality on which we rely to decide when patients are in trouble or not. And using these parameters is particularly important. Note that the correlations between these parameters, fractional area change and TAPSE, with their corresponding MRI parameters is only modest. However, threshold values have been published and can be used to follow these patients.
Thank you. And there's another question. Do we recommend annual echo for adults with tetralogy of Fallot repair? That's a great question. Definitely, the adult congenital guidelines would say that all patients with repaired tetralogy of Fallot should be seen annually with cardiac imaging. Echocardiography is often utilized, specifically when we're looking at valvular abnormalities such as tricuspid regurgitation, but it's also center-specific. The annual recommendations for echo is based on whether or not you are doing cardiac MRIs at regular intervals as well. So I think you have to look to patient-specific factors and center-specific factors to guide your choice in that, but we certainly use both modalities heavily.
Another question is that in the table and in the slide before the last, we said that MRI is not routinely used, but in the last slide we said that MRI is routinely used in adolescents. Let me just clarify this. During the until age 8 to 10, that is the first decade of life, MRI is only used selectively, which means not routinely. After the first 10 years of life, that is in adolescents and adults, we and many other centers use MRI routinely in these patients. It's very common to get a cardiac MRI for baseline evaluation of biventricular size and function and pulmonary regurgitation somewhere around age 10 to 12. And then the frequency of subsequent MRIs depends on the patient's baseline data and clinical course. So I hope that this clarifies this question.
There's another question regarding the average lifespan for tetralogy of Fallot patients. In general, it is excellent and should be considered similar to patients with well-repaired heart disease. And so specific factors come up, but without those arrhythmias or ventricular dysfunctions, patients do quite well.
Another question is, can you estimate the mean and diastolic pulmonary pressure in the presence of right ventricular outflow tract obstruction? I think the answer to that is probably no, or at least it is the presence of RV outflow tract obstruction introduces a major complication in the assumptions that underlie the estimation of pulmonary artery pressure, which basically assumes that there's no obstruction to blood flow between the MPA and the RV and diastolic pressure.
So thank you. There are other questions here. We will try to email you the responses, and we appreciate everyone's interest.
Thank you, everyone. On behalf of ASC, I would like to thank Dr. Jiva and Dr. Valente for their presentations this evening, and a special thanks to everyone who took the time to join us for this evening's webinar. We hope you enjoyed the interactive experience.